So today I'm going to be doing a little bit of a review on the abdominal emergencies. Now, I'm not going through the entire chapter in this video. I'm doing a portion of it. Understand that this is part of your medical section. Now, medical is going to be on the boards or national exam. The text that I am using is right here. It's the Nancy Caroline ninth edition. A little expensive, is what it is. But yeah, we're going to be diving into that. So, of course, like, subscribe. If you like this stuff or you have any questions, feel free to ask. It's what I'm doing, it's what I'm here for. All right, let's get into this. So, the first thing I have to say about the medical section of this exam, the one that you're preparing for, is you got to know medical terminology. Okay, for those of you who are taking notes, which I highly recommend, there's going to be several different words that I'm going to say, and I'm going to say the definition of. I would recommend that you jot them down. These are things you need to be studying. Test questions could be worded in multiple different ways, but if you don't know the words or the terminology, it makes it extremely challenging to answer. Obviously, if that makes sense, right? So this first word that we're going to look at is tracheoesophageal fistula. Now, before we even talk about what that means, you got to know what a fistula is. It's here on the screen. It says a fistula is an opening of between two portions of body or between a body part and the outside of the body. Okay. So if you look at the name here, it says tracheal esophageal fistula. So you can already understand what's happening here. There's a connection between the trachea and the esophagus. Okay. Now, it says methods of acquisition. So this is how it happened. Some of them, believe it or not, it can be congenital. I just got to say that some people are born with this. It can be a death sentence. So understand that if there is a tracheoesophageal fistula, and there needs to be surgery, right? But cancer, trauma, right? Tumors, penetrating wounds. We already said that it could be genetic. But if it says, oh, that food moves into the lungs, obviously pneumonia, sepsis is going to be an issue. These people can die from that. So I'll move through a couple of these things. Says it will need or require surgical repair. Like I said, I'm going to get my head out of the way here. Okay, talking about a esophageal stricture or stenosis. Let's put my head here. Understand here that a term stenosis, you'll see this a lot in different medical terminologies. Stenosis means like a narrowing. So if you see here of the esophagus, there's a narrowing point right before the stomach. And this stenosis makes it difficult for obviously food to pass, right? Says it could be due to inflammation, tumors, infection, or even acid reflux, especially acid reflux over time. It says that the patient could present with volumes of secretion, dysphagia. Dysphagia with a G means difficulty swallowing, right? Dysphagia with an S means difficulty speaking. It says this dysphagia will progress into odinophagia, which means painful swallowing. Okay, all these words you have to please write them down, know them. Says ensure a stable airway. Consider glucagon for patients with obstructions. Now, this is a very interesting conversation because most people know glucagon for the use of hypoglycemia, right? So if we're unable to obtain an IV, we can always go glucagon IM. Just know that 1 milligram of glucagon is going to take a little bit of time for you to start seeing marked increases in that blood sugar, but we can also use it to assist with patients that are choking or have that sensation of choking. Okay, glucagon does help in these patients. Have the patient sit upright, be prepared to assist with oral secretions if they're having difficulty swallowing. Absolutely. Acute inflammatory conditions. Let's get after it. States inflammation, natural response to injury. We all know that. Helps white blood cells destroy or seal off in the invading agent. Change in vascular permeability. Remember that permeability just means it allows for these cells to become leaky, allows for a fluid gradient to change, and fluid can either come into cells or out of cells. This is why there's inflammation, because there's an excess of fluid in those locations. Bacteria moves into the bloodstream, then that's what causes sepsis. Understand sepsis is a systemic uh, infection. So there's an infection that's going throughout the bloodstream. Body will respond with generalized inflammatory response. An autoimmune condition, please know what this means. Autoimmune diseases means the body is attacking or killing its own cells for no defined reason. There's a lot of autoimmune disease that are out there. We're going to talk about a couple in this chapter and understand that, believe it or not, some autoimmune diseases are acquired over time. A lot of them are genetic. Okay. What's interesting is that they say it's still unclear, which is wild. That we have this much technology and they still don't know what's causing these autoimmune diseases. So the first one is peritonitis. Peritonitis, what I would recommend you know is that the peritoneal cavity is this cavity in which all the abdominal organs kind of are housed in, right? And this when you see this term peritonitis, remember the last term itis means inflammation. Now, what can possibly cause inflammation of the peritoneal cavity would be more of like a rupture of a hollow organ, and the hollow organ basically spills out its contents into that peritoneal cavity, causing infection or causing swelling of that peritoneal cavity. Can cause a lot of pain and will definitely cause sepsis if left untreated. So, some symptoms here: bored, hard abdomen, not the muscular type. Febrility or febrile, or no, not seizures. I was going to say temperatures, tachycardia, anorexia, dehydration. It's saying that these patients are critically ill. So let's be mindful. Peritonitis can be bad news. What are we doing for it? How are we managing it? Support the vital signs. Treat for shock, which means fluid management. Now, fluid management doesn't just mean let's start two large bore IVs and flood somebody with fluid. Remember, we're trying to sustain a systolic blood pressure of at least 90. I would say 90 to 100. We don't want to just keep giving fluids just to give it. Okay. Another thing, antiemetics, something like Zofran or aldosterone, 4 milligrams could be considered for these patients just to assist them with the nausea and vomiting. Another interesting thing here, it says administer norepinephrine for sepsis. So that's an interesting thing to say because there's several different pressors that are out there, but understand the mechanism of this shock, right? We say septic shock causes widespread vasodilation, thus decreasing cardiac output. So fix, how can we technically fix this blood pressure or this perfusion issue is by clamping down on these blood vessels. So something that's more alpha driven was like norepinephrine versus dopamine and epinephrine, which have a lot more beta properties, which would increase the heart rate and maybe its contractility. The use of norepinephrine can be preferred. Cholecystitis and biliary tract disorders. It says some biliary tract disorders. There's a lot of them. And that word CHOL, please know that that is talking about the gallbladder. A lot of different disease processes there. Gallstone formation. Again, the cause is unclear. Increased production of bile or decreased emptying of the gallbladder. Look at these 5 Fs. I thought that was interesting. Fair, so it's talking about Caucasian, overweight, fat, or obesity, women that are between the ages of 40 to 50. These are the people that are most likely to have a gallstone formation. Pretty interesting. I never knew that until reading this chapter. It says after eating a fatty meal, the patient can have severe upper right quadrant abdominal pain that develops. Pain begins as food is emptied from the stomach. one thing on this slide that I want you to pay attention to is the Murphy sign. Again, the medical portion of the national exam can throw out a lot of terms and a lot of different practices, one of them being the Murphy sign. Now, what the Murphy sign is you take the tips of your fingers and you'll place it underneath the right rib area, and you apply pressure as the patient inhales, right? As they inhale, the diaphragm drops. And as the diaphragm drops, there's a chance that you could put pressure on the gallbladder itself. And if pressure is placed on the gallbladder itself, and this patient has cholecystitis, the patient will experience a lot of pain. And this pain is known as a Murphy sign. So pretty interesting. If you didn't know that, you might get a test question on it. Uh, you're welcome. Nausea, vomiting, fever, jaundice. There's a lot of stuff that goes on here with the gallbladder. Pain meds, medication for nausea, IV fluids. You're going to hear that a lot for a lot of the management with these different abdominal emergencies. Typically, what I like to tell students is with the medical chapters, it's not mainly about, hey, how am I going to treat it? But it's what are the signs and symptoms and what are the names and what does it mean? Uh, you can really narrow down your answers on your tests if you understand what it is. Okay. A lot of the treatment stuff is all the same. Okay. It says, here we go, appendicitis. Fecal and other matter, it will build up in the appendix. Okay, remember your appendix is located in your lower right quadrant. And what's wrong with once the appendix gets impacted, it starts to and get inflamed and it can rupture. Okay, your appendix is it deals with the immune system. People do get them removed, so don't think that it's like a mandatory thing that you must have. But understand that somebody with an appendicitis that is left untreated can die eventually from septic shock from it. Like before, I stated that you have to know some definitions. Here's some three different ones that you might see. First off, before we talk about the definitions, let's look at the three different presentations of appendicitis. We have early, ripe, and rupture. In early, there's peri-umbilical pain, nausea, vomiting, low-grade fever, and a loss of appetite. Peri-umbilical pain. Okay. Ripe is pain in the lower right quadrant. This is known as the McBurney's point. Again, write this down. McBurney's point. Rupture, decrease in pain, decrease in pressure, generalized pain, and rebound tenderness. Now, rebound tenderness just means that I apply pressure to the abdomen, and then when I release my hands, then the patient experiences pain. That is rebound tenderness. Let's take a look at a Dumphy sign. Dumphy sign is severe abdominal pain in the right lower quadrant when coughing, a Dumphy sign. And Rovsing sign is pain in the right lower quadrant upon palpation of the left abdominal quadrant. Two more notes that I would definitely write down in my notes if I was studying for that exam. Always accept, always assess for sepsis. When assessing for a sepsis, what I would recommend you do, put end-tidal capnography on your patient. I'm trying to pay attention to low end-tidal capnographies. Remember, this is a metabolic acidosis. I'm going to have high heart rates, potentially lower blood pressures, maybe even decreasing O2 sats, increasing respiratory rates. These are all different things that I'm looking for. It says volume resuscitation, use norepinephrine if crystalloids are not effective. We talked a little bit about why. Diverticulitis. Three different definitions here. Again, diverticulum is a weak area in the colon that begins to have outcropping, so it's like outpouchings, that turn into pockets. And these pockets is where like debris can basically get stuck in the colon, and it causes a lot of pain and discomfort for the patient. Diverticulosis is the condition of having diverticula, right? And then diverticulitis is the inflammation of these diverticuli. So maybe it's becoming infected or your body is it's basically irritating that colon and causing pain for the patient is diverticulitis. Now, with these patients, typically they get told that they have to have a special diet. They can't eat certain seeds, they can't eat popcorn, they can't eat certain things that are going to get stuck in those outpouchings. Here we go. Low fiber diet creates more solid of a stool and increases risk of disease. Um, so this is why low fiber is a problem. These patients need more fiber. If feces gets trapped in diverticula, inflammation and infection can occur, which is understood. Abdominal pain usually localized in the left lower abdomen. That's a great thing that I would want to know if I was taking this test. Diverticulitis is abdominal pain, usually localized in the lower left quadrant. Classic infection signs, constipation or diarrhea. It says if adhesions develop, there will be a narrow diameter of the colon, can result in a constipation or a bowel obstruction. Our goal is just to make the patient comfortable, analgesics and antiemetics, just like everything else we've talked about so far. Pancreatitis, I have seen this on multiple exams. Pancreatitis, obviously, it's inflammation of the pancreas. Now, your pancreas doesn't just deal with insulin, it also deals with digestion. Okay, so it does create enzymes to break down foods. Um, it says occurs when tube carrying enzymes becomes blocked. Sharp pain in the epigastrum area. Okay. Pain in the epigastrum. Scary part about pain in the epigastrum, we get to see a lot of this with different abdominal emergencies, gastroenteritis, and other things. They can mimic a MI, right? An acute myocardial infarction. Some patients, they do think they're having a heart attack when they get this kind of pain. It says that this pain radiates to the back. Why? Because the pancreas is kind of located retroperitoneal, right? So it's behind that peritoneal cavity. Fever, muscle spasms. Love to see this. Colon sign around the umbilicus, gray Turner signs along the flanks of the patient. Most test questions that I do see where pancreatitis is the answer, patient usually has some sort of internal bleed going on. Okay, so be mindful when reading these type of questions. Fluid resuscitation, analgesics, same stuff. All right. Talking about chronic inflammatory conditions, inflammation of all or part of the GI tract. The first thing it wants to talk about is inflammatory bowel disease. This is not IBS. This is a disease. So it's actually damage or altering of the actual GI tract itself. Okay. Definition covers both ulcerative colitis and Crohn's disease, which we'll be talking about. And exactly what I wrote here, or what I just said, damage to the GI tract wall itself. It says these patients are at greater risk of having cancer, GI cancer. Okay. Generalized inflammation of colon or colorectal cancer as well. Causes a thinning of intestinal wall and weakened rectum. Wow, it says it peaks between the ages of 15 and 25, and then 55 and 65. More often in women than men, and family history is a definite component of it. So, some signs and symptoms. It says gradual onset of diarrhea, discharge of mucus via the rectum. Okay, that's an interesting one. Hematochezia, bright or they it's bright red blood coming from the rectum. In some tests, you'll see the terminology frank blood. Tenesmus, feeling a full of rectal fullness, like you have to go to the bathroom or you have to have a bowel movement. I would write that term down as well. Tenesmus, and even skin lesions. With ulcerative colitis, the management determine the degree of hemodynamic instability, check a blood pressure, what's cab refill, what does my patient present with, treat with fluids if they're showing signs of shock. Remember, we're just trying to manage that blood pressure. Crohn's disease, a little bit different, even though it is dealing with the GI tract. Understand that Crohn's disease is actually a autoimmune disorder. Okay, remember your body's attacking its own cells, and in this case, in the GI tract. It says series of attacks leave scarred, narrowed, or weakened portion of the small intestine, and this can lead to a bowel obstruction. People with Crohn's disease also have to have a very specific diet. Some serious weight loss, skin problems, chronic abdominal pain, a terrible thing to live with. Some pre-hospital care focus on managing general management says volume resuscitation, nausea, pain, remember analgesics and antiemetics, man. A lot of the same stuff here with abdominal emergencies. Okay, irritable bowel syndrome, abdominal pain, and bowel habit changes. Hypersensitivity of bowel pain receptors, hyperresponsiveness of the smooth muscle, and believe it or not, there is a psychiatric disorder connection to IBS, which is an interesting topic. They do state that most, I can't say most, but there is a direct correlation to anxiety, depression. Um, there are some links to those. It's not saying that everybody with IBS has anxiety, but there is a direct link to it. Hyperresponsiveness can cause spasming, constipation, bloating, and diarrhea. Typically will begin during childhood and can be triggered by stress. Another thing saying that it's psychologically linked. It's a chronic condition. It does have flare ups. Most people that have it, they know what foods are going to cause like a flare up. So one word in here that's like kind of out there is steatorrhea. Typically that means that there's like a excess fat, like fat from food content in the bowel movement. So in the stool, there'd be excess fat within the bowel movement. So the textbook says for management, um, it's what's interesting here is it like really focuses on the patient's psychiatric possible issues, right? Assess the patient's mood and relay concerns about depression. Um, I know several people that have IBS, and it's just certain foods they just can't, they have to stay away from. Right, acute infectious conditions. GI infection occurs when contaminated food is ingested or the GI tract ruptures. Whew, that does not sound fun at all. Okay. GI tract rupturing or an infection. Damage may allow contents to be released into the surrounding tissues, and we already discussed what this can cause. Peritonitis, absolutely, rebound tenderness, sepsis, and possibly even death. Jeez. With acute gastroenteritis, it says condition involving an infection with fever, abdominal pain, diarrhea, nausea, and vomiting can be caused by various organisms, typically enter fecal oral route. Um, Acute gastroenteritis. Wash your hands. Symptoms may show anywhere from several hours to several days, can last 2 or 3 days. Um, I do know gastroenteritis again can mimic a heart attack, so be mindful. Dehydration, hemodynamic instability, electrolyte imbalances. Um, we're just treating symptoms here. Okay. It says determine the degree of fluid deficiency and rehydrate the patient. So, fluid management, analgesics, antiemetics. Teach the patient about safe food and water use. Okay. Um, Interesting stuff. Rectal abscess caused when ducts carrying mucus to the rectal area becomes blocked. And we all know when a duct becomes blocked, it does create inflammation and can form abscess. It says it'll allow bacteria to grow and spread to the anus, and it's twice as likely seen in men. No bueno. Management, the only difference in management here is it says avoid the Fowler position. because when you place somebody in a Fowler position or seated up, a lot of that weight and pressure goes onto their anus, right? On their butt. So it says transport them in a lateral position for most comfort. Liver disease, cirrhosis. Please know what that is. Cirrhosis, disease of the liver. Okay. Can be marked by portal hypertension, deficiency with coagulation, um, and diminished detoxification. Because remember, that's what your liver does, right? It detoxes. So your patient's going to have some issues going on. Remember, the portal vein connects your liver to your stomach or your intestines, rather. So just know that that's going to cause some serious complications if the liver can't do its job. It says in the first stage, the patient will experience joint aches, weakness, fatigue, nausea and vomiting, anorexia, pruritus, known as itchy, like an itchy feeling, and they'll start to bruise, which is an interesting one. Coagulation problem. Some photos behind me here. We got jaundice being showed. Um, I know it says ecteric conjunctiva. Another term that you might see in a test, they'll say conjunctival icterus. All that means is jaundice. It just means a yellowing pigmentation that you'll see in the sclera of the eyes. Remember, your sclera should be white. So if there's any yellowing, just like you see in this photo here, that's a bad sign of cirrhosis. I know up there also it states alcoholic stools. Alcoholic stools just means it's like the stool actually becomes like a pale color and it looks more like clay. Okay, that's an alcoholic stool. Ascites means edema or fluid built up in the stomach. So again, like I said in the beginning, there's a lot of terminology stuff that I'm going to be saying in this lecture. Hopefully this is helping. Pre-hospital care, again, supportive. An interesting thing, though, that it says about cirrhosis is if you do use meds, use lower end of the medication dose. Okay, because you got to remember that meds, some meds, not all meds, but a lot of meds do get detoxed through the liver. And if the liver is damaged or the liver's not working appropriately, these medications could last inside the patient's bodies way longer than intended, right? Because their body's not really metabolizing it correctly. Liver disease, hepatic encephalopathy. It says brain impairment due to diminished liver function. Brain impairment due to diminished liver function. It says that this could be caused by increased levels of ammonia, diminished cellular energy supply, and change in the blood brain barrier permeability. Pretty interesting. Can range from mild memory loss to even a coma. Some interesting stuff here. Attention deficits, the patient can't really comprehend. Impaired complex reasoning. Shuffling gait. Okay, the patient has like the gait is usually like your walking pattern. Now it becomes like more shuffled. Okay, so maybe appears to be off. A lot of the times, we could always ask family. Hopefully, there is family there. Does this appear normal for this patient? And tremors, we know is as of shaking. Bradykinesia. Patients they become a little bit slower. Like typically, you'll see in somebody who has like Parkinson's disease, maybe late stage. They move a lot slower, and you could see that they have kind of like a shuffle, or they definitely have the tremors. All those things can be found in patients with hepatic encephalopathy.
So the treatment for liver disease or hepatic encephalopathy is not much. There's not really anything we can do. Hopefully, we'll even know what it is, by talking to the patient. We can just be supportive. If they have any LOC status changes, just make sure we're checking everything else, right? I always tell people, if you have a patient who's altered, four things I want you to check: blood pressure, BGL, pupils, head trauma, right? We want to try to figure out why this person is altered. Let's move on. Going into obstructive conditions, right? It says rectal obstructions tend to occur in young men. We're going to talk about the different types. Obviously, young men are more prone to it, and esophageal obstructions tend to occur in young children, more of the choking. So, here's what we're talking about with obstructions, right? Bowel obstruction, condition in which intestines are unable to move material through the digestive tract, paralysis of the intestines, and intestinal lumen diameter compromises. It says with esophageal obstruction, kids, it's typically when they're choking because small children tend to put things into their mouth and, they want to taste or bite things, and it happens where they accidentally choke. Okay. Now, take a look at this entrapment thing, because this is a easy test question. When they talk about esophageal sphincters, there's two different sphincters where there could be an obstruction. For children, it's the entrapment location of the upper esophageal sphincter, the UES. For adults, it says it's the entrapment of the lower esophageal sphincter. Okay. All depends on where that sphincter is located in the esophagus. Obviously, if it's in the upper esophagus, probably a little bit easier for it to come out of the oral pharynx. If something gets lodged in the lower sphincter, that's closer to the stomach itself, um, sounds like they're going to need to do surgery. Remember, dysphagia with a G means difficulty swallowing, and drooling are the primary symptoms of esophageal obstructions. It says airways a primary concern. Put the patient in high Fowler's position. Manage oral secretions and suction. Glucagon, remember, is a treatment for choking. It's funny how they don't mention abdominal thrust or nothing, right? Remember, if somebody is actively choking, we need to get the object. Well, don't rush to go grab glucagon. Rush to get the object out. Abdominal thrust. Remember, if they're infants, start with 5 back slaps, followed by 5 chest thrusts. Small bowel obstruction, it says, is most often caused by post-operative adhesions. So maybe somebody who had some sort of surgery in their GI tract now might have a adhesion or some sort of scarring that's occurring in their GI tract, and that can cause a small bowel obstruction. Okay, some signs and symptoms: intermittent abdominal pain, diarrhea, nausea, vomiting. It could even lead up to constipation. What are we doing about it in EMS? Supportive care, monitor blood pressure, volume resuscitation, antiemetics, right? A lot of the same exact stuff that we've been talking about. The only thing that changed a little bit is the use of a nasogastric tube. Remember, nasogastric tubes are used to suction stomach contents. So obviously, if there's an obstruction, stomach contents are basically piling up, and we need to get rid of them, and they're not passing through the GI tract. So if you remember how to size up a nasogastric tube, you take from the nose, let me grab a wire. You take your NG tube and you want to measure it from the patient's nose, around the ear, down to the patient's xiphoid process. We take that location, we tape it, and then we go ahead and start applying or inserting that nasal gastric tube through the patient's nose all the way until you get to your tape. You secure that to the patient's face, and then you're able to suction stomach contents. Large bowel obstruction, a little bit different, right? Because now this is in the colon, caused by either mechanical obstruction or colon constrictor. It says imaging studies determine the location and the extent of the obstruction. It says can be easily treated, not by us. Take them to the hospital. Nausea, vomiting, distended abdomen, absent bowel sounds. It says even peritonitis, signs of bowel that the bowel has ruptured, are some signs and symptoms of a large bowel obstruction. For management, pain management, antiemetics, man. Fluids if needed. Makes my life a lot easier, right? Knowing that they're all the same. Take a look at that hernia. Abdominal wall hernia. It says the organ or structure protrusion into an adjacent cavity. So you can see why um, that the hernia could be problematic. If it starts pushing too much, the hernia starts to get too large and it pushes on other organs and compromises function. To check for an inguinal hernia, it says place fingers on the lower abdomen, instruct the patient to cough. We often see these hernias also when people move, they try to get up out of their chair, or, you know, you'll see a bulge occur. It says the hernia is caused by a condition that causes intra-abdominal pressure. Could be obesity, standing for long periods, heavy lifting, straining during a bowel movement, and even COPD can play a role in abdominal wall hernias. That's an interesting one. So this is a good time for one of those. Let me write down some notes on different words. It says that there's four different types of hernias. First one is reducible. Okay. I made sure to put the definitions on here for you guys. Reducible returns to its normal location either spontaneously or by manual manipulation. So wherever that hernia is at, it comes out and it goes back to its normal location. Incarcerated, organ is trapped in its new location. This can often cause something like a bowel obstruction, right? The organ actually gets trapped by the hernia. A strangulated hernia, the intestine is trapped and squeezed, causing a lack of blood flow to the area. And this is when pain or the patient will experience pain. Okay. So the hernia actually stops blood flow. It doesn't just push up against the organ and traps the organ, but it actually stops blood flow to the organ. That's called a strangulated abdominal wall hernia. Last one here. Let me get my big head out of the way. Incisional hernia. Intestinal contents herniate through the surgical incision. Wow. Okay, so it's actually saying that there's a incision to the abdominal wall, and actually intestines are coming out of the abdominal wall, known as an evisceration. This can occur with, I would imagine, some pretty severe hernias. Position of comfort, pain management. Please know your pharmacology for analgesics, right? Know what medications you're going to give for pain. Rectal foreign body obstruction might not be everything you're thinking about right now. Um, Obviously, it's going to interfere with defecation. Originates from the upper GI tract or anal insertion. Obviously, there could be foreign bodies that get stuck up there, and people call 911, lay the person on their side, take them to the hospital, and they'll remove it. But we're going to talk about a couple other things. Okay. This patient is going to present with rectal pain. It says pain with defecation. It says determine if the rectum has been perforated. So if there's actual damage, this can cause peritonitis and sepsis. Obviously, assault can be a big deal with this. So we do want a history. We want to ask some questions, see if we have to have PD involved in this type of call. Absolutely. Do not remove the object. Do not go in there trying to grab things. It says seat the patient laterally, put them on their side, give them analgesics, and be compassionate and non-judgmental. I'm surprised. Okay, so there are some. I know there's other ways like that. There could be like hard stool. I'm sure we're going to get to this in this chapter. But some people do get impacted with hard stool and stuff. So it's not always a foreign body. It could be something internally from the patient. Mesenteric ischemia. Remember, the mesenteric system is the GI tract. So ischemia means hypoxia. So there's lack of oxygen to the GI tract here. Now, what can cause this? It says there's four main causes of interruption of blood supply, and that's acute arterial embolisms, acute arterial thrombus, found vasospasms, and mesenteric venous thrombus. So clots, embolisms, and spasming of the venous system. It says could be gradual or sudden onset, severe pain, nausea, vomiting, diarrhea, possible blood in the stool. Just says patients will require rapid transport, monitor closely, check vitals, give fluids, and analgesics. Again, neoplasms. Neoplasms are typically like a tumor, right? Or some sort of growth. Says caused by errors during cellular production, um, benign or malignant. Remember, benign just means that like non-cancerous, malignant could be a bad thing, right? It's spreading. It says any portion of the GI system can develop a neoplasm or cancer. Risk factors, diet, high, it says high in red meat and low in fiber, smoking, or could be hereditary. Says some of the most common signs of a tumor or a neoplasm in these patients: abdominal pain, rectal bleeding, anemia, change in bowel habits. Always, always, always patients that have abdominal pain, we always want to ask about bowel habits. I know it's an awkward conversation. When was the last time you had a bowel movement? Is that normal? What was the consistency like? What was the color like? These are questions we need to ask. It says if cancer is found on the right side of the colon, the patient will have bleeding and diarrhea. Left-sided tumors tend to cause obstructions of the bowel. Nothing that says basically for management, there's nothing we're doing. We're taking them to the hospital. Resection may be required, so the patient needs surgery, and colon colostomy will be needed. Pancreatic tumors, gradual presentation mistaken for benign conditions, malaise, nausea, vomiting, mid-epigastric pain, back pain, anorexia, weight loss. These are with pancreatic tumors. It says particularly fatal. Wow, really bad. It says care supportive. Most of these patients will have a DNR. They know that this is like an end of life uh, issue. Hepatic tumor. Remember, hepatic is on the liver. It says alcohol consumption, Hep B and C are risk factors as well. Patient's going to have pruritus, itching, jaundice, rickettsia. I had to put the definition on here because I was like, what? Profound malnutrition and weight loss. It's another good buzzword that I would definitely write down. Ascites, abdominal pain, hepatomegaly, uh, which is an enlarged liver, by the way. A lot of things that we expect to see in our hepatitis patients as well. Says just support the vital signs, right? And another interesting thing, I remember I brought this up earlier, issues with the hepatic system or the liver. Use the lower end of acceptable ranges of your medication. Do not go too high on the meds because the patient has a hard time metabolizing or detoxifying from it. So, prevention strategies, the last thing that we're going to be talking about in this chapter, how can we prevent ourselves from having these GI conditions? Eat high fiber foods, drink a lot of water, and stop drinking so much alcohol. And also eliminate smoking. Smoking is has been shown to cause a lot of GI problems. That's it. Hopefully this helps. If you guys are studying for your medical portion of the National Registry, again, I can't stress this enough. Learn your medical terminology. This section is heavy on medical terminology. Know what things are, know how where to find them, know how the patient's going to present. And it's not a bad idea to know what the treatment is. But even in this chapter, you saw all the treatments the same. In this chapter, it was fluid management, pain management, antiemetics for just about every single abdominal emergency. Makes our life a lot easier, especially for a student who's trying to take a test. Right? So I wish you guys the best of luck. If you have any questions, please ask and let me know what other stuff you would like to see me go over. All right? Good luck.